Mr. Michael Algozo. Our group is here to present a case of a 35-year-old Filipino female with hemophilia. Next slide, please. Here is the outline of our case presentation. Next slide, please. For the patient history, a 35-year-old, 75-kilogram Filipino female was rushed to the emergency department with the chief complaint of prolonged menstrual bleeding that lasted for 3 weeks. She complained that she has bleeder's disease and has had multiple episodes of inflammatory joint bleeding. She had a history of undergoing blood transfusions due to her bleeding disease. Her physical examination reveals swollen, immobilized knees. She has a distinctive mild jaundice and an enlarged liver and spleen, which is characterized by the tenderness on the right upper quadrant and left upper quadrant of the abdomen. Next slide, please. Her laboratory results indicated that her platelet count is at 74,400 microliter, which indicates a thrombocytopenia, and the prothrombin time test is at 13 seconds, and the activated partial thromboplastin time test is at 43 seconds. Next slide, please. Upon performing the history taking, it was revealed that both of the patient's parents are carriers of hemophilia A disorder. The patient's mother is a heterozygous carrier without clinical manifestations. The father, on the other hand, was also diagnosed with hemophilia A. Given her laboratory results, she was immediately admitted and transfused with 2 units of thawed fresh frozen plasma per day for 4 days in the regular patient ward. She was also given platelet concentrate, 2 units per day as well for 4 days. And lastly, she was given 0.3 microgram per kilogram of desmosporin diluted with 15 to 30 ml saline solution and admitted her intravenously. Next slide, please.
So for the test ordered, the first test is complete blood count. A complete blood count, or CBC, is a comprehensive test that examines various components of blood, including red blood cells, white blood cells, hemoglobin, hematocrit, and platelets. Despite individuals with hemophilia experiencing significant or prolonged bleeding, their CBC results typically appear normal, although they may have lower hemoglobin levels and red blood cells counts. So another test is prothrombin time test. Blood clotting involves distinct pathways such as the extrinsic pathway and the common pathway. So an extrinsic pathway that necessitates thromboplastin, calcium, and factors 1, 2, 5, 7, and 10. The prothrombin time test assesses the clotting factors in the extrinsic and common pathway. By measuring the time required for the blood to clot, it primarily evaluates factors 1, 2, 5, 7, and 10. Reduced levels of these factors can result in slower blood clotting. However, individuals with hemophilia A and B generally exhibit normal prothrombin time test results. Another test is activated partial thromboplastin time. To screen for coagulation disorders related to the intrinsic and common pathway, the activated partial thromboplastin time, or APTT test, is employed. The intrinsic pathway relies on factors 1, 2, 5, 8, 9, 10, 11, platelet lipids, and calcium for clot formation. The APTT test measures the clotting time and evaluates factors 8, 9, 11, and 12. When these factors are abnormally low, blood clotting may take longer. APTT tests can result and indicate delayed clotting time in individuals with hemophilia A or B. So the last test is clotting factor test, or the factor assays. It is important in determining the specific type and severity of hemophilia. Hemophilia severity is typically categorized as mild with 5 to 40% of normal clotting factor activity, moderate with 1 to 5% of expected activity, or severe with less than 1% of normal activity. So the patient is presenting symptoms related to bleeder disease or hemophilia. Hemophilia is a medical condition characterized by a deficiency or absence of vital blood clotting factors which are crucial proteins necessary for normal blood clotting. These tests are conducted to assess the severity of patients' hemophilia and utilize the result for precise diagnosis and the implementation of suitable treatment options based on the underlying symptoms she is experiencing. Next slide, please.
Fresh frozen plasma is composed of 200 ml of plasma in each unit, administering 10 to 20 ml per kilogram of body weight increase factor levels by 20 to 30%. In the case of the patient weighing 75 kilograms, she required 1,500 ml of fresh frozen plasma to elevate her factor levels. This quantity is equal to 8 units of fresh frozen plasma to adhere to the recommended maximum. 2 units of fresh frozen plasma were transfused daily for a total of 4 days. As a result, the patient APTT values improves from 43 seconds to 30 seconds. The patient received platelet concentrate as well according to the recommended dosage of 1 platelet concentrate per 10 kg of body weight. The expected increase platelet count is approximately 40,000 microliter. As the patient weighs 75 kg, a total of 8 units of platelet concentrate were administered, resulting in a cumulative increase of 320,000 platelets. Her platelet count improved from 74,400 to 394,400. Next slide.
For the correlation analysis, the patient's clinical manifestations and laboratory findings point towards a bleeding disorder and liver disease. The symptoms reported, such as hemarthrosis, menorrhagia, and the patient's self-identification as a bleeder, initially raised our suspicion of hemophilia A. Moreover, the laboratory tests have effectively associated hemophilia A as the cause. The patient's physical examination revealed swollen and immobile knees, which are consistent with the typical representation of hemophilia A. Nevertheless, further investigations were needed to confirm the diagnosis. The laboratory results showed anemia and thrombocytopenia, indicated by lower hemoglobin, red blood cell count, and platelet count. Additionally, the prothrombin time fell within the normal range, but activated partial thromboplastin time was prolonged, exceeding the reference range. These findings suggest an impairment in the blood clotting process. The patient's history of receiving blood transfusions raises the possibility of contracting hepatitis C from untreated blood product. It is worth noting that the treatment of viral diseases with factor concentrates began in 1984, prior to which hemophilia patients were at higher risk of developing hepatitis B or C from these concentrates. To confirm the presence of liver disease, bilirubin and liver enzyme assays can be performed. Liver disease can lead to an enlarged spleen due to poor liver circulation, which causes increased pressure in the portal circulation. An enlarged spleen can sequester and clear platelets more rapidly, leading to thrombocytopenia. Additionally, reduced platelet function, as demonstrated by abnormal platelet aggregometry, could explain the patient's menorrhagia. Next slide, please.
For the conclusion on medtech realizations, hemophilia A in women is considered a rare case as it is more common in men. This can be attributed to the number of copies of genes in the X chromosome. Nonetheless, women may either inherit this kind of disease or acquire it from several factors. In this scenario, the disease is inherited. In hemophilia A clotting protein, specifically factor VIII, is missing or defective. Common symptoms associated with it are menorrhagia and hemarthrosis. In this case, similar symptoms were presented, which are the main indicators of the disease. In addition, swollen and immobile knees were indicated in physical examination. The APT is prolonged, PT is normal, and the platelet count is low. Therefore, all the medical history, physical examination, and laboratory tests suggest that the patient is suffering from hemophilia A. The diagnosis and severity of hemophilia A varies from case to case. For instance, some patients with hemophilia A have normal platelet counts. Hence, the job of a medical technologist is to perform proper and accurate laboratory tests. Furthermore, the assessment of medical history, patient history, and symptoms must be considered as critical as it affects the rule out of diseases. It must be noted that rare cases should not be regarded as an error in diagnostics. Next slide, please. So here are our references. This ends our case presentation. Thank you for listening.